Bienvenidos a un nuevo plano.
Bienvenidos a un nuevo plano.
Un nuevo viaje.
Un nuevo viaje.
Nuevo viaje.
Donde la visión es bidireccional.
Bidireccional. ARI.
ARI. Exposición comercial de tecnología oftalmológica.
Every new day, the world awakens with countless moments of joy, discovery, and hope. New stories and new memories. As Biotech Healthcare, we are here to enrich these moments, improve quality of lives, help people live better all around the world. We are with them in every moment they look through life, in every moment they mirror their beauty, or as they walk strongly towards their dreams. Our journey was founded on a vision for providing light and visual excellence to all parts of the societies. Established in India in 1999, we've been empowering communities worldwide to access advanced healthcare technology and products. And in less than a quarter century, we've introduced over 50 different products, expanding into 3 different verticals in the medical device industry. We are here to enable access to innovation.
Hello, good morning again from the sunny Alicante. I'm proud to show to you this session 10 about innovation in intraocular lenses and precisely focus on new extended depth of focus lenses. We have an outstanding panel of distinguished speakers, and we have Joaquin Fernandez co-leading this session with me, and we're going to have a presentation from him, from Fernando Llobet, Nabil Kamel, Florian Kreitz, Emilio Pedrotti, Alalda Nasuri, and Jorge Sanchez Cañizal. We shall have a debate with Seradaya and Demi Gatinel on the stage as well, and we open with a keynote lecture that will be shared by Joaquin and by me. So go ahead with this first keynote lecture in order to put in the scope the concept of EDOF lenses. Thank you.
Bueno, pues queremos compartiros la clasificación funcional basada en evidencia de las lentes de visión simultáneas que desarrollamos y que la Sociedad Europea de Cirugía de Catarata y Refractiva, SCRS, la tiene como base para conseguir un consenso mundial. Ya está habiendo conversaciones tanto con ASCRS, con Asia Pacífico, para poder conseguir que podamos tener una clasificación global a nivel mundial y todos hablemos de lo mismo. Estas son nuestra declaración de interés que puede afectar a esta presentación. Y esta es la editorial de la que hablamos, que fue publicada este agosto por el Working Group de Visión Funcional de la SCRS. Estáis viendo presidentes actuales y electos de la SCRS, pasado, el editor en jefe de la Journal Cataract Refractive Surgery, y entre todos llegamos a proponer esta clasificación en busca de ese consenso global. ¿Cuál es el punto de corte para el partial range of field? Como estábamos proponiendo, puntos de corte de 0,2 Lomar y 0,3 Lomar. Sabéis que el 0,3 Lomar sería 0,5 decimal, 0,2 Lomar sería el 0,6 decimal. Bueno, pues si la lente, el range of field es menos de 2,3, se quedaría como partial range of field. Quedaros con el punto de corte 0,2 Lomar, que es importante, y para ese punto de corte menos de 2,3 dioptrías, parcial. Si adquiere para ese punto de corte de 0,2 más de 2,3 dioptrías de profundidad de campo, hablaríamos de la full. Parcial menos de 2,3, full más de 2,3 para 0,2 Lomar. Vamos a ir familia por subfamilia. En las parcial Si para ese mismo punto de corte 0,2 Longmark conseguía menos de 1,2 dioptrías de amplitud de campo, hablaríamos de las narrowed. Estas serían las monofocales de toda la vida, ¿vale? Si adquiriera una profundidad de campo de menos de 1,58, estaríamos hablando de las enhanced. Bueno, las que ya sabéis que existen en el mercado, las monofocales enhanced, y las extended, que serían las E2, adquirirían una profundidad de campo de menos 2,3 dioptrías. Monofocales, narrowed, menos de 1,2, menos de 1,58 enhanced, extended, menos de 2,3. Si nos vamos a la full range of field, todas ellas, para el punto de corte 0,2 Longmark, tienen más de 2,3 dioptrías de profundidad de campo. ¿Qué es la diferencia? La transición entre lejos, intermedia y cerca. Fijaros, aquí es prácticamente continua, solamente hay una pérdida de menos de 0,05 Longmark. Esto sería casi solamente 3 letras de una línea. Entonces estaríamos hablando de las monótonas, ¿vale? De las continuas. Full range of field continuos. Si la caída entre lejana, intermedia y luego subida cerca es menos de 0,14 Longmark, esto es menos de una línea y media, estaríamos hablando de las smooth, porque la caída es smooth, suavizada. Y la caída steep, la gran pronunciada entre lejos, intermedia y cerca, si es más de una línea y media, estaríamos hablando de las steep, que estas serían las bifocales de toda la vida. Las steep bifocales de toda la vida, las smooth, las trifocales antiguas, y las continuas, las que la ISO propone como full visual range. Estáis viendo aquí completo totalmente el global consenso que proponemos, con la nomenclatura completa, con la abreviada que os proponemos desde la SCRS. Y gráficamente, mirad qué simple. Las partial, las que se quedan cortitas, las narrow, serían las monofocales, un poquito más las enhanced, un poquito más las extended, y las full visual range, las que tienen un descenso continuo, las que tienen un descenso smooth y las que tienen un descenso steep. Muy simple. Nos iremos acostumbrando y fijaros, estas son las terminologías, la similitud entre ellas, ¿no? La concordancia, la correspondencia entre nomenclatura óptica, con estándar, con la clasificación funcional y con la que se propone de la SCRS con un nombre abreviado.
Hello. Now, following the presentation that has been made by Joaquín Fernández, let me explain to you another perspective on premium IOLs that I want to share with you. First of all, we have different conditions today to accomplish a successful modern cataract or refractive lens exchange surgery. But one of the most important is to choose an adequate intraocular lens that creates the adequate optical performance for the patient to enjoy spectacle independent vision for all distances. In this regard, we have a universe of premium IOLs. We have multifocal diffractive, basically dominated by the trifocals, multifocal refractive that could be rotational, symmetrical, or sector varifocal. Then we have 5 types of lenses, and finally, we have already here the accommodative lenses of new design. We have to understand the progress and the confusion on premium lenses. First of all, there has been a huge commercial bias that has made the clinician difficult to understand which are the best lenses that we have to choose for our patient. Second, the ISO and the ANSI standards have not been effective in clarifying this confusion to the practical clinician because they mix optical and functional concepts. And finally, you have been told by Joaquín Fernández that the ESRS Functional Vision Working Group has provided an evidence-based functional classification, which is extremely useful, but not complete. Why it is not complete? Because optical category and functional category should be defined separately. Optical category is defined through the true response evaluation in the optical bench, and functional category should be defined by the focus score and the functional patient subjective symptoms reported by the patient. And without this last one, the functional category, you can really understand what you are doing in your patient. So how to unveil the premium IOL confusion? How to avoid the bias? First of all, let's explain briefly that diffractive multifocal lenses, basically the trifocal lenses today, provide very good near vision, usually, but they always have halos and glare. They are unavoidable. Multifocal lenses refractive provide in general good vision at all distances, but at the cost of distortion when the power is more than 1.5 diopters. This is something that happens to these lenses. This Two factors makes neuroadaptation necessary. That means that the brain has to adapt to this new type of vision, and neuroadaptation failure is possible. EDOF lenses have a different principle. They stretch the light, creating an area in which the focus is sharp enough to be defined for normal purposes or functional purposes, but obviously never as a monofocal lens. These EDOF lenses try to avoid most of the problems that multifocal lenses have, but usually at the cost of less near vision. We have 5 categories of premium EDOF lenses. One, based on spherical aberration, type 1. Second, based on the pinhole principle. Then we have what we call fake EDOF. They are really diffractive or refractive lenses with low near vision arc that masquerade the focus curve of the EDOF lenses, but they are not based in the principles of EDOF. In other words, they are not based in optical manipulation of the spherical or other aberrations in the benefit of near vision. They are really multifocal lenses. Then we have other lenses that are with optical geometry manipulation, and they have been named with the wrong term of enhanced monofocals. They are not monofocals, they really are EDOF lenses, and might be type A with a non-linear progressive profile, and B with a central optical artifact for near vision. This is a paper that you should read in order to understand better the universe of EDOF lenses and to know how and who is who. Then we have finally accommodative lenses, which are just appearing. They provide a normal optical performance, and they have a physiological performance, and as usually in every functional function, they are somehow variable. And the only one existing today with peer review evidence is the Lumina ACO-lens accommodative lens. How to choose the best premium lenses? Based on how good is the quality of radial image, and finally look at the clinical outcomes in the monocular, the focus curve, and how is the contrast function, especially the mesopic one. Look at this paper because this defines how we should expect from different lenses different types of quality of radial image on clinical basis. In this paper, we describe how different lenses behave differently in the human eye, as far as the human eye is an off-center system, and they do not reproduce the same characteristics and advantages that they show in the optical vein. Look here, for instance, the MA60, SA60, a very traditional monofocal lens, versus an EDOF lens, the mini well, which is type 5A. These lenses have a high change in spherical aberration, leading to unprecise quality of radial image. As you see here, these lenses give bad vision. Look here the different types of multifocal, monofocal, and EDOF. They are really different, and the closest they are to the bidimensional point spread function of a monofocal, the better will be, and obviously the better the neuroadaptation process. Different the focus curve will define to you how useful will be this given lens for far, intermediate, and near. But this should have a good quality of radial image, or otherwise the quality of radial image being bad will not allow neuroadaptation process. Same with the focus curve of EDOF lenses. They have, as multifocals, different profiles, and you have to choose depending on what you want to get in your patient, never sacrificing the quality of radial image. Look here, accommodative lenses. This accommodative lens, the Lumina, provides this PSF function and the swell ratio that is equivalent to a monofocal lens, because if they are really accommodative, they are monofocal for different distances depending on the optical change in the power of the eye, led by the action of the ciliary body. This lens obviously has no impact in contraceptive function and no dysphotopsia, but should prove that they have real change in power depending on distance, as you can see in this image, in which one eye is implanted with a monofocal, the other with a accommodative Lumina, and look here how with distance the power of the eye is changing. That means it's accommodating. Obviously, you have to expect from a physiological function variability. Not everybody has the same strength or the same size or weight, and this variability reflects the real accommodation in real world. In summary, today we have an extensive portfolio of premium lenses, confusing, and the surgeon needs to make choices based on objective evidence-based data. The clinical quality of the limits offers an optical element to base this opinion based on clinical objective evidence-based data. The PSF ratio correlates with visual acuity, and remember the MTF value correlates with the CSF and the conservative function, and this is offered by the system. The focus curve offers you the information about how useful will be this lens for different distances. And today you have to consider premium accommodative lenses probably in the future will lead the market as far as they replace the optical physiological function of the crystalline lens. This is the online course of our university offering 500 hours of teaching activities online in English, which is available to all of you and from which ARI is the continuous medical education part. I thank you very much for your very kind attention.
Okay, we are going to continue after this splendid presentation and classification that is absolutely necessary for all ophthalmologists. We are going to talk about the different EDOF lenses. The first lens we are going to talk is the EDOF lens, the Elon lens from Medicontour, and Joaquín Fernández is going to present the lens. Let's go, Joaquín.
Bueno, queremos compartir con vosotros nuestros resultados clínicos con la lente Elon de Medicontour. Bueno, ya sabéis nuestros conflictos de interés, somos consultores con Medicontour y bueno, siguiendo un poco el guión, la tecnología, la profimelometría, estáis viendo cómo se basa en un perfil refractivo óptico con dos zonas centrales a 2 milímetros y con dos zonas de transición que la unen para conseguir esa profundidad de campo, ¿vale? La zona de transición ahí donde está la clave de la profundidad, cómo se consigue la profundidad de campo. Estas son las características que nos comparte la casa comercial sobre la lente. Y cuando comparamos la profilometría, ¿vale?, de esta lente con otra bastante conocida del mercado, con los mismos perfiles ópticos similares, veis cómo ese perfil óptico es ampliamente similar, ¿no? Son dos zonas de curvatura incremental con esas otras dos zonas de transición. Como se consigue la profundidad de campo, bueno, en este perfil, la profundidad de foco, en banco óptico estáis viendo que esas zonas de transición, conforme se van incrementando hasta los 20 microns, estáis viendo cómo se consigue la amplitud de la distribución lumínica en esos diferentes focos. Cuando vamos ya directamente a la MTF axial para un modelo de ojo de 3 milímetros de apertura en 50 pares de líneas por milímetro, estáis viendo esa distribución de la profundidad de foco comparativa entre una y otra lente y son sumamente similares. Si nos vamos ya directamente a las expectativas clínicas que podemos tener con nuestros pacientes, nuestra muestra es bastante particular porque quizás sea un poquito añosa, con lo cual las agudezas visuales podrían estar ligeramente reducidas. Como hemos comentado antes con Liberty, los resultados son reportados 85 candelas por metro cuadrado, que son condiciones peores que en clínica solemos medir, que son 200 candelas a metro cuadrado, y probablemente los resultados que podéis tener en clínica sean mejores que estos que hemos reportado. Si nos vamos a la eficacia de la lente, ya sabéis que tiene que ser en monocular, corregida a la mejor distancia, ¿vale? Bueno, pues estáis viendo corregida a distancia, veis esa media de prácticamente 0 logmark, con una desviación estándar muy bajita, como estáis viendo, se consigue un 87% de los casos. En intermedia estaríamos en 0,1 logmark, con una desviación estándar también estrechita, estaríamos en un 20-25 en ese porcentaje, y en cercana sí tendríamos un 0,3 con una desviación estándar un poquito mayor, porque puede depender quizá un poquito más de pupila. Cuando nos vamos a la eficacia del procedimiento, ya sabéis que en binocular y no corregida a distancia. Entonces sería este caso, la binocular no corregida a distancia, corregiríamos a distancia 0,08 logmark con esa desviación estándar, 0,13 en intermedia y en cercana estaríamos en 0,21, un poquito mejor obviamente que una línea más que en monocular. Estáis viendo cómo la profundidad de campo en términos de agudeza visual y sensibilidad al contraste viene a darnos una partial range, un perfil de partial range of field, luego lo veremos extended, como estáis viendo. Y si nos vamos ya a resultados reportados por pacientes, fijaros cómo comparativamente las molestias con respecto a fenómenos fóticos que les molesten o sean muy molestas son prácticamente nulas, ¿vale? Y sí es interesante tener en cuenta la independencia de gafas total, intermedia y cerca, pero para cerca, en intermedia y en lejos, disculpad, pero para cerca sí habría que avisar a los pacientes que es probable que tengan que utilizarla. Pero algo sumamente interesante es que estos resultados reportados por pacientes, cuando los recoge a corto plazo con respecto a un año, mejoran. Fijaros cómo a los 3 meses, 3% de los pacientes se quejaban algo o mucho y pasaban a un 0%. Y fijaros cómo la visión en cercana, la satisfacción, satisfecho, muy satisfecho, estaban en un 43% y subían a un 90%. Con lo cual es una lente que dándole tiempo sí que hay un fenómeno, quizás no tanto de neuroadaptación, sino de satisfacción, un proceso de satisfacción un poquito que hay que darle un poco más tiempo con respecto a las lentes difractivas. Tendríamos que cambiar de Elon, de Liberty a Elon para disminuir el riesgo de disfotopsia positiva. Esta es una pregunta bastante interesante. Fijaros, medimos el fenómeno fótico con el equipo, el alómetro del grupo de Mejomé, quizás para nosotros el más interesante, el Light Distortion Index, el Light Distortion Analyzer, este equipo. Y con respecto a lo que hemos publicado comparativamente en Liberty en binocular, tendríamos un 13% de Light Distortion Index, un parámetro que mide el fenómeno fótico, y tendríamos la mitad en binocular con Elon, ¿vale? Esto es interesante que lo tengamos en cuenta porque hay que convertir el fenómeno físico, el fenómeno fótico, perdón, que son basadas en pruebas psicofísicas, en disfotopsia, en clínica, en psicométrico, ¿vale? En cuánto molestan a nuestros pacientes. Este paper, que le tenemos mucho cariño, realmente poníamos el cutoff, definíamos el cutoff del índice de distorsión lumínica para el cual los pacientes estarían desde moderadamente molestos, muy molestos, extremadamente molestos, a pasar a prácticamente muy poco molesto o nada molesto. Sería un 15,2% del índice de distorsión lumínica de ese fenómeno fótico. Pues fijaros este esquema que es sumamente interesante, teniendo en cuenta que el 15,2% de índice de distribución lumínica separaría lo moderadamente molesto de lo apenas molesto o prácticamente nada, ese fenómeno fótico lo tendríamos en un 13% para Liberty y la mitad para Elon. Pero luego eso se convertiría en disfotopsia, en molestia o muy molestia solamente en un 7% de los pacientes con Liberty y un 0% de la Elon. Yo creo que eso os da información suficiente a la pregunta que os hacíamos. Con respecto a la clasificación funcional, ¿dónde estaría Elon? Respecto al paper que publicamos con el grupo de Filomena y que podéis tener todas las lentes que están en nuestro mercado en esta aplicación, el IOL Evident. Ya sabéis que si pasáis a Pro, el poquito de dinero que puede costar va directamente los beneficios a la Fundación Elena Barraquer. Nos diría que esta lente está dentro del grupo de las Partial Range of Field y para ello Extended, ¿vale? Puntos de corte están totalmente definidos en la aplicación, luego podremos debatirlo. En resumidas cuentas, Elon estaría ahí, en esa Partial Range of Field Extended. Los resultados reportados por pacientes mejoran de 13 a 12 meses y esos poquitos pacientes que se quejan de fenómeno fótico a los 3 meses se quedan en 0 a los 12 meses y la disfotopsia podría disminuir con respecto a Liberty, pasarían de un 7% de los pacientes quejándose o quejándose mucho a un 0% con Elon.
Thank you very much, Joaquin. And now the next speaker will be introduced by Gonzalo Bernabeu.
Okay, the next speaker is Fernando Llobet. Fernando Llobet is going to talk about the EMV. It's a EDOF lens from Reiner that has a splendid behavior in a small mini monovision, as we are going to see. And I want to say a tip about this lens. Don't forget this lens is the only lens in the market with a positive spherical aberration. This is very important in hyperopic LASIKs. For me, this lens is the lens I choose when I have a cornea with negative spherical aberration as a hyperopic LASIK. So this tip is very good for don't forget the lens in these cases. Fernando, start the presentation.
Ray-1 EMV is an intraocular lens-enhanced monofocal hydrophilic acrylic. Use control positive spherical aberration to spread light along the visual axis, elongating the focal range from far to intermediate. It does not use diffractive or light splitting optics, so it will not induce more dysphotopsias than with a standard monofocal intraocular lens. We plan mini monovision for emetropia in the dominant motor eyes and low degree of myopia in the dominant sensory eyes. The objective be changing the second eye to monovision is for the depth of field to reach beyond the intermediate to also provide near vision, maintaining good binocular vision at a distance. To assess motor dominance, we use the whole-in-hand test and sensory dominance, the plus test. We propose a study to evaluate visual outcomes and patient satisfaction after implantation of an enhanced monofocal intraocular lens for mini monovision. A study approved by Ethical Committee of Hospital Clínico San Carlos. We designed a prospective multicenter interventional case series study that include 51 patients with consecutive bilateral primary cataract surgery and implantation of an enhanced monofocal IOL RAI1A in V. The target refraction was -1 diopter in the no-dominant eyes and emetropia in the dominant eyes. Preoperative and postoperative values are shown in the table and standard graph. As can be seen, the binocular visual results confirm good distance and intermediate vision and a stable near vision. Regarding the refractive results, mean manifest refraction spherical equivalent was around emetropia and -1 diopter for the dominant and no-dominant eyes respectively. Subject reports visual satisfaction and spectacle independence was obtained with CATCAS 9FF questionnaire. All response report a 3 months spectacle independence for distance, see to wall recognizing phase regarding subtitles on TV, and intermediate vision prior when shopping, and more than 30% of patients not requiring glasses for near test. Regarding the test, in the newspaper, seen in handcraft. Patient report results using their own questionnaire show that 98% of patients report being satisfied with their vision. 96% report no difficulties with night vision or driving at night. All the patients would again the same technique. In conclusion, subjects implanted with the enhanced RAI1 MEV monofocal IOL with mini monovision achieve excellent distance vision and high overall vision quality. The spectacle independence was achieved for far intermediate distance. Satisfaction levels were high. Thank you very much.
Thank you very much, Fernando, for this nice presentation. Now it's my pleasure to introduce to you to Nabil Kamel. He's going to explain to us the LuxSmart from Bausch & Lomb. This is a needle lens from this company, Bausch & Lomb. Go ahead, Kamel.
Good morning, ladies and gentlemen. It is a pleasure to be with you today. First of all, I'd like to thank Professor Dr. Alio for his kind invitation and all the organizing committee. I'd like to present the new head of IOL LuxSmart from Bausch & Lomb, based on the pure refractive optics technology. Actually, it is not that new anymore. I've been using this lens for 2 years. We've implanted over 800 lenses with excellent results, and this lens right now is my reference for EDF lenses. The concept of the lens or the concept of using the spherical aberrations to increase the depth of focus was explained by Dr. Bernard in 2011, stating that in optical modeling, the versions of the optical aberrations measured on an optical curve was well correlated to the subjective depth of field obtained for the same pupil size. Applying this, we can see here the change of depth of focus in relation to the induced aberrations. I mean, like inducing only a spherical aberration of the fourth order would increase the depth of field up to 30%, which can go up to 45% inducing a spherical aberration only of the sixth order, and reaching the maximum levels that we could achieve of 63% was achieved by merging the spherical aberration of fourth and sixth orders of opposite signs. So applying this concept, the design of the LookSmart lens has a central EDF center of 2 millimeters, which with increased depth of focus. It is created by the combination of the fourth and sixth order spherical aberration of opposite signs, which is the one that gives us the largest range or the largest depth of focus. There is a transition zone that is designed to smoothly decrease the optical versions from the center to the periphery. This transition zone would take part of fourth and sixth spherical aberration orders. It is designed to control the trajectory of light rays to ensure no light is outside the range of vision, and in this way there is no light loss. The peripheral part of the lens is monofocal aspheric surface aberration free. This lens has a very interesting feature, which is that the optic is resistant to tilt and decentration. It is a very tolerant lens in this aspect. It is hydrophobic lens with clear or violet light filtering, one-piece 4-point fixation, which gives very, very good stability to the lens, mostly important, of course, in toric intraocular lenses. We participated in a multicentric study conducted by Dr. Ali Naurouzi, myself, Dr. Jorge Alio del Barrio, and Professor Jorge Alio, to evaluate the visual performance after unilateral and bilateral implantation of this lens. The results were really amazing. We can say that there was 100% spectacle independence for most intermediate activities at 60 centimeters, almost 100% spectacle independence for far vision or far visual activities. 40% of patients even had spectacle independence for 40 centimeters distance, which is not the main idea from an EDF lens, but it is an added advantage. 90% of patients had 100% of their contrast sensitivity conserved, which is an excellent result, actually. We can say that no patients complained of blurry vision at different distances, so it gives us a continuous full range of vision in a natural way. We have to highlight that this lens is sensitive to residual myopic refractive errors, even as small as minus 0.5 diopters. As well as the same happens in residual astigmatic errors. On the other hand, it is quite tolerant to residual hypermetropia till even plus 1 diopters, which affects very slightly the performance of the lens. Patient satisfaction was practically 100% in far and intermediate distances. No patients complained of any permanent photic phenomena, and no patients reported any imbalance or between both eyes and the vision in both eyes when it was implanted unilaterally. So it is very tolerant in this aspect. Our results coinciding with the results of Dr. Stodoka in one of his very first studies, visual acuity, monocular, binocular, excellent results. The monocular defocus curve with very good range. The modulation transfer function area was excellent The levels are really high, which means that there is a very good quality of vision. This is directly related to the quality of vision and thus better visual acuity. It was very good within the range of 2 millimeters up to 4.5 millimeter pupil size. Same thing, 3 millimeter up to 4.5 millimeter size, there were minimal or even no halo and glare. So, I would like to highlight some practical points and recommendations. The LookSmart lens gives an excellent quality of vision for far and intermediate distances, and even most of patients have very good near vision, to the point that many cases with bilateral implantation don't need optical correction for near vision. This lens gives best results in pupil diameters between 2 to 5 millimeters. Of course, 2 millimeters because the central part is the part that has the EDOF design. So it is important to take that in consideration. It is very important to explain to the patient that the range of the focus of this lens is between from far till 60 to 80 centimeters. If the patient gains more near vision, well, this is always an added advantage, and it happens frequently. The LookSmart lens is very sensitive, as we said before, to the residual myopia. So you have to take that in consideration and always try to implant the lens with the power that would give the very first positive residual defects, which is very well tolerated by the patients. As we said before as well, that the lens is not very tolerant to astigmatic residual defects above -1 cylinder. So in low astigmatic defects of -0.75, -1, even up to -1.25, we combine femtolaser arcuate incisions with the cataract procedure. On higher astigmatic values, we usually use the toric version of the lens with very good results. To obtain best results, we have to treat any existing MGD, as it affects negatively the quality of vision of patient and the patient satisfaction in all premium IOL implantation. We usually treat the patients with dry eye and MGD with IPL laser before and after surgery as part of the protocol of premium cataract surgery. So to conclude, the LookSmart as an EDOF IOL provides us with an excellent option to improve the quality of vision in our demanding patients, achieving excellent far and intermediate vision, usually with improved depth of focus that helps the patient in his daily activities. Compared to multifocal or trifocal intraocular lenses, it is true that the EDOF IOLs have their limitation for near, but on the other hand, they provide natural continuous vision of high quality in the other distances, preserving almost normal contrast sensitivity and without suffering the adverse phenomena como dysphotopsias, halos, and glare. Thank you so much for your kind attention. I leave you here with an image of one of my ancestors doing one of the very first cataract surgeries.
Okay, we are going to continue talking about the EDOF lenses, and the next lens is the Innova Advanced from VSY Biotechnology, and the doctor is Florian Kretz from Germany. Come on with the presentation.
Hello everyone, my name is Florian Kretz. I'm the owner, CEO and founder of Precise Vision Augenärzte in Germany. I'm happy to talk to you about the Innova Advanced EDOF IOL. Here are my financial disclosures. The Innova Advanced is a non-diffractive hydrophobic EDOF IOL. It's on the same platform as the Maestro 6mm optic overall 13mm. Haptic design is C-loop, no optic haptic angulation, and it's available as a toric version already. It already comes preloaded on a glistening-free material. The material is proven to be absolutely glistening-free. It was compared by the University of Utah to the Acrisoft IQ and the Technis with even better results than those, but it's like the Maestro that I've shown before. The platform itself, also the Maestro platform with the C-loop haptic design, works very well in small capsular bag, but also when the capsule shrinks, those patients won't have tilt or decentration, or at least a very low grade of it. Due to the material, it unfolds very quickly, but you can see that in the videos later. If we look at the expectations, it's an EDOF IOL. We want sharp vision for distance, a good intermediate vision, and still a near effect. Low profile of halo and glare, should be glistening free. Good preconditioning and preloaded is preferred. If you look at the light tailoring technology, you can see those sinus curves with a larger one in the center and the peripheral sinus ring around it, creating a good far vision and a good intermediate range with still a little bit of near vision effect. If you look at optical benchmark results and compare it to the Vivity, you can see the distance visual acuity on the optical bench in different apertures is significantly stronger. Intermediate is on the same level, especially in a larger aperture than 3 millimeters, and the near effect is also a little bit stronger. If you look at the energy distribution of the IOL, you can see that most of the energy goes from difference, and depending on the aperture size, there is a distribution towards distance to further reduce halo and glare and scotopic pupil sizes. Visual acuity, especially compared to the Vivity, but also compared to the monofocal, shows a high peak for far and a very smooth down-going curve from intermediate to near, but over the Vivity limit. Very interestingly, the point spread function of the Innova Advanced shows a better image than the Acrisol Vivity, with far less ring structures around it and apparitions, and still in a near vision range between +2 and +2.8 diopters, an acceptable focus. That can also be seen in the use of pictures, especially also with different pupil sizes, where the visual quality is not really reduced and far. In intermediate, you can see there is a good intermediate effect with the 3 millimeter pupil. You can see here one implantation video. It's a straightforward cataract surgery, a little bit sped up. I used the same keratome for paracentesis and incision. We just use HPMT to fill the anterior chamber and protect the endothelium. We do a CCC with Utrata forceps, try to make it round so you have the perfect optic overlap. I usually try to target 5 to 5.5 millimeters. Hydrodissection with a combined hydrodelineation. Then it's a straightforward chop and stop technique. Good hydrodissection, then basically you hardly have to do any polishing. I use a Salter cannula to polish the remnants, especially in the equator and the posterior capsule. I don't polish the anterior capsule. Then bimanual IA to remove the remnants of the cortex. And then, like with the Maestro, I implanted IOL just with the irrigation port. You can see here the Innova Advanced. Just to show that, you can see here the inner structure of the optic, especially like the secondary ring about the central bump. Just some HPMT in the cartridge. You can see from the material it's very easy to load it. So you just press the optic in, close it slightly, and fold the haptics on top of it. You don't have to put the haptics all the way through. Most important is that the trailing haptic is bent so it doesn't get stuck between the silicone plunger. Then irrigation port in the anterior chamber. You can see the lens comes out lovely. And it unfolds and it centers very fast. A little bit of polishing. And you can see the inner ring again directly inside of the Purkinje images. And basically that's the surgery. So very straightforward, very effective, and a very handy IOL for patients. Here's some data from the early multi-center trial, 92 eyes of 63 patients. Significant increase in uncorrected distance visual acuity from 0.9 logMAR to 0.1, but you can see intermediate uncorrected 0.02 and even near with 0.3 is absolutely acceptable, with most patients reaching a target between minus 0.5 to plus 0.5 diopters. It's absolutely glistening free, and we couldn't detect any decentration or tills, no adverse events, with a high satisfaction rate. So thank you very much for your kind attention, and feel free to contact me anytime if you have further questions.
Okay, thank you very much, Florian. And now is the next speaker, Emilio Pedrotti, who is going to explain to us the Lucidis intraocular lens from Swiss Advanced Vision. Emilio, you are next.
Good morning. I'm Professor Pedrotti from the University of Verona. Today I'm happy to share the result of a study conducted at the Verona Eye Clinic on the quality of vision and outcomes after bilateral implantation of a pseudo-non-diffractive beam intraocular lens, especially the Lucidis IOL. These are my financial disclosure. This lens represents a significant advancement in extended depth of focus technology, offering a great solution to improving visual outcomes for patients. The Lucidis IOL is built on unique optical technology that enables it to extend the depth of focus while maintaining a constant resolution and a peak in light intensity. This is achieved through the constructive interferences of light waves generated by the aspheric surface at the lens center. The resulting beam, known as a pseudo-non-diffractive beam, diverges only after certain distances, allowing continuous near-to-distance vision with minimal scatter. As you can see from this table, this technology doesn't create a trifocal point, but instead the optical zone of the Lucidis lens is designed with a 6 mm spherical zone for distant vision and a 1 mm central button dedicated to near and intermediate visions. This hybrid design ensures that light distribution remains independent of pupil size, with a 50-50 split between distances and near intermediate visions. This allows for excellent visual clarity across a range of focal points. The Lucidis IOL is a foldable hydrophilic acrylic lens featuring a 6 mm optical diameter with either 10.8 and 12.4 mm in total diameter, depending on the model. In my experience, the biggest one is better. It has square edges with closed-loop optics for stability. The lens hybrid refractive aspheric design allows for seamless transition between near and far vision, offering a plus 3 diopter addition for near task on top of the normal distance correction. This flexibility makes it highly adaptable to different patient needs. Our study focused on evaluating both objective and subjective visual outcome after the implantation of the Lucidis IOL. We enrolled 25 patients who had significant bilateral cataract, no prior ocular disease, and astigmatism of less than 1 diopters. All underwent bilateral surgery with the IOL implanted 1 week apart. We assess visual acuity as various distances, near 40 centimeters, intermediate 60 and 80 centimeters, and for far 4 meters at 3 months post-surgery. Alongside, we perform the focus curve allometry contrast sensitivity measurement. We also measured objective quality of vision measurement, and we administered the NEI-related quality of life 42 questionnaires. As a result, we enrolled 25 patients with a mean age of 68 years, and the mean IOL power was 19 diopters. Our results show that the Lucidis IOL provides excellent visual acuity, particularly for near and distance vision. In fact, in binocular condition, it is higher than 0 logMAR for far distances and just above it for all the other measurements. Importantly, the differences between uncorrected and corrected visual acuity were minimal, which highlights that the lens is repeatability. The focus curve confirmed the high-quality visual acuity provided by the Lucidis lenses across multiple distances. Visual acuity remained above 0.05 logMAR between plus 0.50 and minus 2.50 diopters of divergence, indicating strong performances in intermediate and near visions. Amerometric measurements further supported this finding, show a stress ratio of 0.2 consistent with high quality, optical quality. Regarding contrast sensitivity, there were no significant differences between patients who received the Lucidis IOLs and those with monofocal lenses across various lighting conditions. Similarly, halometry result demonstrated that lucidness performs similarly to the monofocal IOL in terms of minimizing glare, a crucial factor for nighttime. Finally, patient satisfaction was very high. The NEI-related quality of life 42 questionnaires revealed that most patients experience excellent near and distance vision without needing additional correction, and there were no significant activity limitations due to visual impairments. Their overall satisfaction with the correction was also strong, further validating the less effectiveness. In conclusion, the Lucidis IOL represents a significant advancement in EDOF technology, providing an excellent balance between near and distant vision, while maintaining high-quality visual performances and patient satisfactions. Its unique pseudo-non-diffractive beam technology allows for continuous vision across a wide range, and this study supports its effectiveness in delivering great outcomes. Thanks for your attention.
Thank you very much, Professor Pedrotti. Excellent presentation. Now it is my pleasure to introduce you to Alal Danasuri from Saudi Arabia, Maghrabi Institution, the outcomes and insights from clinical data on Esquelio EDOF intraocular lenses from IST Vision Care Company. Thank you, Alal. This is your time.
Ladies and gentlemen, I'm Alal Danasuri. I'm very happy to participate in this recorded session. Many thanks to Professor Alio and his team for the kind invitation. In the next few minutes, I'm going to share with you our results in a prospective study to assess the clinical outcome of the Esquelio EDOF IOL. I have no financial disclosures. Esquelio EDOF is a one-piece hydrophobic acrylic lens that uses what's called a phase ring structure design. This is simply an hexagon in the center of the lens. On the optical bench, it proved to generate conical wave front that extends the depth of focus. However, for us as clinicians, it's more important to evaluate the performance of this lens inside the eye rather than on an optical bench. That's why we designed this study, which is a prospective study on consecutive eyes who received bilateral EDOF Esquelio lens. The indication of surgery was early cataract or refractive lens exchange. 52 eyes completed a 3-month follow-up, and that's what I'm reporting today. The deviation from target refraction at 3 months was minimal, was minus 0.07, with all eyes within 1 diopter and 79% eyes within half a diopter of the intended refraction. Our refractive target was a micromonovision of minus 0.4 diopters, and at 3 months we achieved minus 0.03 in the emmetropic eyes and minus 0.46 in the monovision eyes, very close to the target. The clinical trial suite was used to measure visual acuity, contrast sensitivity, and to generate automated defocus curves. At 3 months, the monocular uncorrected distant visual acuity was 0.03, with 100% of the eyes seeing 0.3 logmar or better. The uncorrected intermediate visual acuity at 66 centimeters monocularly without correction, 95% of the eyes could see 0.3 or better, compared to 6% before the surgery, with a mean uncorrected intermediate visual acuity of 0.1, which is very good intermediate vision. The near vision without correction, and remember this lens is designed for far and intermediate vision, but for near vision, 69% eyes could see 0.3 or better, which is good enough for newspapers or smartphone screens. In order to assess the EDOF property of this lens against the ANSI definition, we measured the monocular distant corrected visual acuity. At 3 months, the monocular corrected distant visual acuity was minus 0.02 logmar, with 95% eyes seeing 0.1 or better. The distant corrected intermediate visual acuity monocularly was 0.1, with 93% seeing 0.2 or better logmar. And also for the near vision, the distant corrected near vision was not bad. In 48% of the cases, they could read 0.3 or better, 20/40 or better with their distant correction. The defocus curve showed an extended depth of focus above 0.2 logmar for a defocus between +1 and -1.5, which is a true extended depth of focus. The wavefront analysis showed a central myopic ring, which is created by the axicon or the ring phase structure in the center of the lens. The contrast sensitivity was very good without glare and with glare, with a slight decrease compared to the normal population, and this decrease is more significant for higher frequencies as expected. The objective scatter index decreased in the cataract eye and increased in the refractive lens exchange eyes as expected, and both ended in 1.3 at 3 months. At 3 months, the subjective questionnaire results showed that all the patients were at least satisfied and would recommend the same surgery again. 12% of the patients had some visual disturbance in scotopic condition, and 50% of the patients could read without near add. In conclusion, a scleroid lens gave excellent distant and intermediate visual acuity with high spectacle independence, very useful near vision, and a very good quality of vision as measured with the contrast sensitivity and OSI. And I thank you for your attention.
Thank you very much, Alain. Impressive results, and this is interesting to have a debate later on. And now it is my pleasure to introduce to you to the next speaker, Jorge Sánchez Cañizal from Spain, from León. He will talk about Techniques Pure C from Johnson & Johnson, experience in this new EDOF intraocular lens. Thank you.
Buenos días, muchas gracias a la organización por la invitación. Vamos a hablar de la nueva lente de Johnson & Johnson Techniques Pure C. Mi nombre es Jorge Sánchez Cañizal, de la Clínica León Ocular, y os vamos a contar nuestra experiencia dentro del Grupo Vista con esta plataforma. Pure C va a ser la lente de la conocidísima familia Techniques, que va a entrar dentro del grupo de visión parcial de foco extendido, que va a ofrecer, siendo una lente puramente refractiva, una visión intermedia y cercana mejorada respecto a una lente monofocal con un perfil de fenómenos fóticos comparable a estas lentes monofocales. Nuestra muestra van a ser 53 casos con una edad media de 66,8 años, intervenidos de catarata o lensectomía en práctica clínica habitual, y hemos excluido a aquellos pacientes con comorbilidad que pudiera limitar el resultado visual o operados de LASIK previo. Como podemos ver, las variables biométricas entran dentro de la normalidad, lo justifica los resultados refractivos obtenidos con una gran precisión similar a la publicada por Barrett. En cuanto al target, es en casi todas las clínicas que hemos participado el primer negativo consistente de menos 0,28 y de ahí el residual obtenido con gran parte de los pacientes en menos 0,25 a menos 0,75 dioptrías. Este SIP miópico nos va a definir esas agudezas visuales sin corrección ligeramente inferiores que con corrección en visión lejana, tanto en monocular como en binocular. En cuanto a los índices de seguridad y de eficacia, serían 1.6 y 1.8, teniendo en cuenta que los pacientes intervenidos de catarata han ganado en su mayoría líneas de visión. En cuanto a las visiones en distancia intermedia monocular, tendríamos tanto sin corrección como con corrección unas agudezas visuales de 0,68, con lo que cumpliría el criterio medio de lente de rango extendido de 0,2 logmar. Si analizamos las agudezas visuales en distancia cercana, como podemos ver, sin corrección obtenemos mejores resultados que con corrección, eso debido al SIG mióptico obtenido en la muestra, con 0,71 y 0,63 en monocular y 0,74 y 0,70 en binocular. Lo que hemos hecho también ha sido una comparativa en 3 ojos de estos pacientes en los que se implantó la lente Eyhance, comparándolo con la muestra de Pure C, y como podemos ver en la gráfica, la ganancia en distancia intermedia y cercana respecto a Eyhance es clara también en esta comparativa, aunque solo es de 3 ojos. En nuestra clínica León Ocular lo que hemos hecho ha sido comparar una muestra anterior de la lente Eyhance y la agudeza visual intermedia y cercana también se ve claramente mejorada con la lente Pure C, teniendo la desviación estándar, incluso el peor de los casos de Pure C igualaría en estas visiones a la lente Eyhance. La satisfacción de los pacientes la hemos medido traduciendo el cuestionario PRISC, la versión 2, y el cuestionario de disfotopsias de Macalinde. En cuanto al reporte espontáneo de disfotoxias, tan solo hubo un paciente, el 4% de la muestra, y en el resto de pacientes que nos reportaron de forma espontánea se les realizó el cuestionario, siendo estas molestias ocasionales en el 12,5% y nunca las percibían en el 87,5%. Esta disfotopsia fue moderada en el 12,5% de los pacientes que la percibían y nunca en el 87,5%. En cuanto a la necesidad de gafa para actividades de visión lejana, el 100% de los pacientes de la muestra no la necesitaron. En agudeza visual, en visiones intermedias, tampoco necesitaron la corrección con gafa o lente de contacto tras la intervención. Y en la agudeza visual o visiones cercanas, aquí 1 de cada 3 pacientes tampoco necesitaron la corrección con gafa y 2 de cada 3 pacientes la necesitaban poco. De estos resultados pues podemos ver el alto grado de satisfacción general del paciente, con un 70% muy satisfecho y un 29,2% satisfecho o altamente satisfecho, y la frecuencia general de visión sin gafas fue del 79,2% y tan solo un 20% la necesitaron, y además con una frecuencia baja. Y como conclusiones de este estudio multicéntrico, vamos a obtener con la lente PureSee unas agudezas visuales lejanas sin corrección en binoculares en lentes, una agudeza visual sin corrección en binocular cercana funcional, que nos va a dar una alta satisfacción tanto en la visión general como en las diferentes distancias de visión de nuestros pacientes, siendo la lente PureSee pues una herramienta más en nuestro arsenal para la cirugía de catarata y de presbicia en el día de hoy. Por último, agradecer de nuevo a la organización por la invitación y especialmente agradecer a todos los centros que han participado dentro del Grupo Vista en este estudio y en la toma de datos y analizar los resultados que hemos tenido con la nueva lente de Johnson & Johnson Technis PureSee. Muchas gracias.
Thank you very much, Jorge. And now we have time for the debate. We're lucky to have again our debate shared with Dr. Sared and Damien Gattinel. They are connected with us, and Joaquin Fernandez will lead the discussion. Joaquin, go ahead.
Thank you very much, Jorge. Well, we are seeing now this head of family, according to the ISO, would be all the lenses that for the cutoff of 0.2 logMAR, it would be 2032 or 0.63 in decimal, achieve more than 1.5 dioptry, but less than 2.5. But we are seeing, according to the literature, a big differences in between head of refractive versus head of diffractive, according to the photic phenomenon and the deep photopsia. Do you think that right now, and of course in the future, we are going to have space enough or quality enough or value enough for head of diffractive lenses, or is going to be a family specifically for refractive profile? Damian, Cheras, what's your opinion?
Well, again, I think this is a kind of strange debate, because what you need is to get the maximum of depth of focus with the minimum impact on the vision, and we know the respective characteristic of those lenses. The trend today is to favor refractive designs. I think it's a bit of a trend, kind of a fashion, I would say, because again, those lenses, they induce some aberrations, which degrades sometimes the distance vision, or they have peculiar refractive unexpected effects, like for example those with a very central portion where the EDOF effect is induced. If you have a small pupil, the patient will experience myopia. So of course, if the pupil is small when the patient reads and large when he doesn't read, it will work more or less. But if the patient has constantly a small pupil, the lens will provide the doctor with the impression that he had a mistake in the IOL power calculation, although there's no mistake there. It's just because a central portion of the lens induces myopia. So instead of all these subtle, fancy denominations blended with marketing aspects, I would rather have maps for refractive EDOF, where you would see a dioptric vergence map, where you would see where the near is added in terms of dioptric power. So presumably you would see that the lens for example, has a 22 dioptric power. If 22 is for distance around the center, has more in the very central zone, or has an annulus of extra power. But that's what we need to have a better idea of how these lenses work beyond the fancy semantics. And that's for the refractive. For diffractive, the symphony was not so popular over time. But if you look at the VVT, although it's quoted a non-diffractive light, there is an abrupt step of about kind of a micron height. And if you speak to any physicist in the world, he'll tell you that if you have on the lens an abrupt step with such a height, it's diffracting light. So it's partially diffracting. At least there is a little diffraction in the process involved. And of course, not a full diffractive lens, but there is a little diffraction. So some lenses where you see a very abrupt or discrete change may use a little diffractive effect to provide the EDOF, although they would not be happy to be called so, because diffraction means halo to make it simple, although again, it's not so much depending on where you start with.
Excellent. Sharaf, I have a question for you. Of course, we would like sacrifice the profile only if we are going to increase the contrast sensitivity and diminish the photic phenomenon. Right now we have trifocal or full range of field, whatever you want to or full range of focus, all these lenses. On the other hand, we have right now the partial enhanced lenses, the monofocal enhanced. Do you think right now or in the future we are going to have space enough for the EDOF lenses, because monofocal enhanced, partial range of field enhanced give us contrast sensitivity MTF in optical band as good almost as monofocal and very low photic phenomenon. Do you think that now we have a space enough for the EDOF, or the balance of monofocal enhanced and trifocal or full range of field is going to diminish the opportunity of EDOF lenses?
The first thing to say is that the ANSI standard, I think, is a bit low for the definition of so-called EDOF lenses. And I think that needs to change, for starters. And I think it needs to be increased. The bar needs to be a bit higher so that these lenses can be categorized. The second thing is a lot of manufacturers, even though their lenses actually are better than the ANSI standard, are listed as enhanced monofocal or monofocal plus lenses. They do that for business reasons. They do not want to go through the process of evaluation and the costs involved, and they would rather have volume of sales than look at the functionality and label their lenses as increased range of focus or EDOF or whatever you want to call it. So you're balancing these two things out. What I find interesting is, I actually have a talk called EDOF, Why Bother? Because really, when you look at patient satisfaction, if they don't have near vision, in my experience, and we also looked at objective data and satisfaction data when we did the ACOS study, we found that there was a strong correlation between near vision and patient satisfaction. If they didn't have near vision, they weren't that satisfied. We make with these so-called EDOF lenses, we've got an improvement in intermediate vision, and that is important for a lot of activities. But when they're missing near, it's a problem. So we've got to look at all these factors. I think what's the benefit of these lenses is for those new entrants into the space who want something that's forgiving, in inverted commas forgiving. They have an option that's available for them. And again, it's this which we discussed in the previous session. There's this obsessive fear of dysphotopsias, which I think personally is overrated. But yeah, they're worried about it, and I don't think that the manufacturers help in talking about dysphotopsias and making it sound like it's a major thing. So I think you balance it right. For my own purposes, I hardly use these kinds of lenses. I have no intention of doing so because I want to give my patients equivalent vision in both eyes and a full range of focus. I know that's what keeps them satisfied. I do use some of them in certain cases, but they're quite few and far between.
Excellent. Well, very fast, 1 minute for Emilio Pedrotti and 1 minute for Fernando. Right now, it's quite similar question. Right now, with partial enhanced lenses, monofocal enhanced, in comparison with EDOF and extended, are you moving one family to another because trying to reducing the photophenomenon and increasing the contrast sensitivity for your patient? Not Fernando, Emilio?
Well, yes, I'm still moving from the trifocal IOLs to EDOF ones, especially the refractive ones that use wavefront technologies, use spherical aberrations, because I think spherical aberration is something that our brain already knew, and the neuroadaptation is not so difficult. And at the moment we can have on the market some platform that allow us to use a few spherical aberration in the dominant eye and as a slightly more amount of spherical aberration in non-dominant eye to increase depth of focus, range of visions, and I performing a study that compared trifocal to that system, and our result is very similar in terms of visual acuity, almost for near, but highest patient satisfaction, mostly related to the quality of vision.
Okay, Fernando, 1 minute.
I choose the monofocal plus lens indication for those patients in warning cannot implant a multifocal IOL. With minimonovision, a good intermediate vision can be obtained without affecting distant vision. For me, it's already more important, but it's not enough for acceptable vision near in all the patients. However, the independent sunglasses for near vision cannot be eliminated. For duration, I don't use this technology in refractive lensectomy, for example. I use in cataract surgery in most selected patients.
Okay. Well, thank you very much. As Jorge Alió tell us at the beginning, we need more advance in the scientific community. We have good enough information about the deeper field of all the lenses. We could more or less have this information. But more and more, we need more information about the contrast sensitivity, at least corrected in distance. It would be ideal also in all the focus curve. But for sure, we need more information coming of evidence about the patient-reported outcomes in terms of independence of glasses, photophenomenon, dysphotopsia. In this field, the reporting, the article, the questionnaire made by the Academy this last year in ophthalmology is very useful, and probably we need more evidence based on that, try to have more information to our patient, to our doctor. Thank you very much for all us. It was amazing your speeching, incredible. Jorge, you can continue if you want.
Oh, thank you very much, Joaquin, and thank you, Ala, Fernando, Professor Pedrotti, Damien, and Serath. This has been a very important debate. I think that we are evolving into the EDOF concept because, as you rightly mentioned, we have at this moment an emerging technology with different types of approaching the same goal, which is intermediate and to a certain level the intermediate vision, the near vision. The variability in the outcomes for near is something that caught my attention. Probably next year we shall devote a special session to this issue, how to get near vision with EDOF lenses. I think that the time is over. We need to close the session. I want to thank you, Roberto, Joaquin, and everybody that has been around for having this session so outstandingly conducted. Thank you very much, and the session is closed. Thank you.